virtually in Ottawa. And I'm going to talk to you a little bit about what I think is the evolving standard of care for people with diabetes and kidney disease, and share with you some of my thoughts about where the field is headed in 24 with some of the latest things that I've been thinking about, and would be interested to hear your thoughts and discussion after the talk. So these are my disclosures, which are all primarily related to my involvement in those clinical trials that Swapnil mentioned, with all of the honoraria paid to the George Institute for Global Health. So I'm going to really focus our attention today on three things. The first you might be more familiar with, which is just recalling the evidence base for some of the new pharmacotherapies that reduce not only cardiovascular disease, but kidney disease progression in people with diabetic kidney disease. But also, secondly, recognize the potential efficacy and safety considerations when using a multi-medicine or combination therapy approach to reduce cardiorenal risk in people with diabetic kidney disease. And finally, which I think is very interesting at this stage, is understanding the potential approaches, theoretical and practical, as well as the opportunities and challenges in implementing what I will call the 4 pillars of kidney GDMT, or guideline-directed therapy for diabetic kidney disease. But firstly, what I thought I'd do is take a step back and just take on a historical perspective of the field over the last 30, 40 years. And if you look at the rates of kidney function decline in clinical trials in the control group going back to the 80s and 90s, you can see that people are losing about 6 to 10 mils per minute per year of GFR. That was attenuated with the ACE inhibitor and ARB trials in the early 2000s, and you look at the rate of decline in those studies, it was about 5 mils per minute per year. And in the intervening period up until credence, if you look at the rates of GFR decline, essentially stagnant about 5 mils per minute per year in all of those clinical trials like Beacon and Altitude that were didn't prove to be beneficial. But now with the new agents, we can see that the rates of decline in kidney function have fallen to about 2.5 mils per minute per year with SGLT2 inhibitors, and potentially even further with the combination use of newer agents. And all of these new clinical trials are fantastic news for patients and for us as clinicians and nephrologists looking after them. And that has been reflected in the KDIGO guidelines for type 2 diabetes and kidney disease. And I'm going to focus really on these 4 classes of medications today, which have been shown, or in the case of GLP-1 receptor agonists, about to be shown to substantially reduce kidney disease progression. And I'm going to borrow from an analogy from the cardiology and heart failure literature, and that is the 4 pillars of therapy, because I think there are many similarities between kidney disease and heart failure. We're all aware of them. And I think this is a really useful framework to think about how we can reduce cardiorenal risk in our patients, and also reduce kidney and cardiovascular events. And the first pillar is our foundation, the tried and tested ACE inhibitors and ARBs. And if you look at the evidence on which our use of these agents is based in diabetic kidney disease, and I'm going to focus today on diabetes and kidney disease, it's really the IDNT and RENAL trials in the early 2000s, which established renin-angiotensin system blockade, in this case with ARBs as standard of care for slowing proteinuric diabetic kidney disease. And for a long time, we didn't have any additional therapies, but we now have, of course, the SGLT2 inhibitors, which we're all starting to use more widely in clinical practice. And what has been so valuable over the last 8 years or so is that these drugs have been now studied across the whole spectrum of kidney disease risk in people with diabetes and indeed non-diabetic kidney disease. The early clinical trials in people with type 2 diabetes enrolled people at lower kidney risk but high cardiovascular risk in the top left-hand corner of the panel. And then we had credence, an exclusively albuminuric type 2 diabetes and kidney disease population, DAPA-CKD, which lowered that UACR threshold to 200 milligrams per gram, and also enrolled people with non-diabetic kidney disease. And of course, last year, EMPA-KIDNEY, the largest and broadest of the SGLT2 inhibitor trials that enrolled people with a broad range of risk of kidney disease progression, including those in the bottom left-hand corner, what I like to call the HFpEF of nephrology, the non-albuminuric low GFR CKD group, which has allowed us to really understand the effects of this class of agent in different types of patients. And I'm going to show you now some of this work you may have seen, but you may not have. And this is the work that we've led through the SGLT2 inhibitor consortium, SMART-C. And this is just the CKD progression trials with treatment effects on a harmonized endpoint. So these trials were all reanalyzed so that the endpoint was consistent across all of the trials, 50% decline in GFR, kidney failure, or death due to kidney failure. And you can see here the treatment effects on this harmonized outcome broken down by cause of kidney disease. That's diabetic kidney disease, ischemic or hypertensive nephrosclerosis, glomerular diseases, and others. And you can see here that overall there's an almost 40% risk reduction in the hard outcome of kidney disease progression, with no evidence whatsoever that this treatment effect varies by primary kidney diagnosis, thus giving us real confidence that these agents should be used alongside RAS blockade as foundational therapy for proteinuric chronic kidney disease. And when we break that down even further into just people with glomerular diseases, I know this is a DKD talk, but I think it is worth mentioning because many people with glomerular diseases also have diabetes or at high risk of cardiovascular disease. You can see here that although the numbers are smaller for FSGS, and of course it's a mixed bag, this is not primary or secondary, we don't have biopsy information for that cohort. You can see here generally consistent effects on kidney disease progression, the harmonized endpoint, with a very clear effect in people with IgA nephropathy. And it's upon this basis that most of us, at least my colleagues in Sydney, are using SGLT2 inhibitors in IgA nephropathy, certainly before we enroll them in clinical trials or use immune modulating therapies in that particular population. I'm going to draw your attention to some newer data that you may not have seen. This only came out last week, but has been shared on social media previously by the EMPA-KIDNEY PI Will Harrington, and that's the effect of SGLT2 inhibition across the whole range of kidney function. This is data from EMPA-KIDNEY, and by virtue of the very long run-in period for the trial, although the trial focused on people with a GFR greater than 20 at enrollment, because of that 8-week period, many people who had a GFR above 20 fell below 20 by the time they were randomized. And you can see here that even down to a GFR below 20, so those 250 patients, there's no evidence whatsoever that the benefits on kidney disease progression are modified by baseline kidney function. And it was very interesting that the UK guidelines have now given a weaker recommendation for starting SGLT2 inhibitors, even in people with a GFR less than 20. So that has really, when you take a historical perspective of where we were even only 5 years ago, not being able to use these agents in people with a GFR less than 45, this is really quite a remarkable transformation. When you look at just the kidney disease trials specifically, and yes, we know that these drugs reduce cardiovascular events, but what type of events are they actually reducing? These are data from the kidney disease trial specifically, and you can see here that there is an overall moderate reduction in cardiovascular death, about a 20% risk reduction, and that magnitude of benefit is most pronounced on heart failure deaths, so non-atherosclerotic cardiovascular events. And now when we've pulled all the data, I haven't been able to show you that today because it's not yet finalized. There is no effect of this class of agent on MI. There is no effect on stroke, but you see, interestingly, reductions in non-cardiovascular death. heart failure, sudden cardiac death with these agents. And I think that's really important when we're thinking about combination therapy, because then now we have other agents that reduce atherosclerotic events, such as GLP-1 receptor agonists. So we have different classes of agents that target different types of cardiovascular events. And of course, the risk of both atherosclerotic and non-atherosclerotic events increases as kidney function declines. So certainly a rationale here for different agents to reduce different types of cardiovascular events in people with chronic kidney disease. This is a theme that I'm going to build upon over the next, during my talk, and that's that these pillars of therapy can potentially interact with each other. We know that RAS blockade has remained underused over the last 2 decades, despite clear evidence in proteinuric CKD patients. And we know that SGLT2 inhibitors reduce hospitalization, acute kidney injury, and hyperkalemia, all antecedent events for discontinuing a RAS blockade. So we did a pooled analysis to explore this hypothesis in Credence and DAPA-CKD, and we looked at the effect of randomized allocation to an SGLT2 inhibitor on discontinuation of RAS blockade. And what we found was a moderate 15% reduction in RAS discontinuation in people treated with an SGLT2 inhibitor, with interestingly more pronounced effects in people with higher levels of albuminuria. And those are exactly the types of patients who you want to keep on RAS blockade, because they're the ones who stand to gain the greatest absolute benefits. So this is a theme I'm going to be drawing on, with certain therapies enabling better use or persistent use of other guideline-directed therapies for reducing kidney disease progression. And you can see here the second pillar potentially supporting or impacting the next one. But we just know that for many patients, the residual risk of kidney disease progression remains high despite an SGLT2 inhibitor. And the best data that underscores that is this work from Credence. And what we did is we looked at after 6 months of treatment with canagliflozin, what people's levels of residual albuminuria was. You can see the panel on the left, and I'm just going to focus on that, is the kidney disease progression, BNC, MACE, and hospitalization for heart failure. But you can see that in the black dots, that's canagliflozin, the level at 6 months of albuminuria lines up perfectly with the placebo patients and their levels of albuminuria at baseline in terms of their future risk of kidney disease progression, underscoring that even after treatment with an SGLT2 inhibitor, your residual level of proteinuria is still the most powerful predictor of long-term kidney disease progression risk, and indeed cardiovascular events. And so we need additional therapies, and that's where, of course, the non-steroidal mineralocorticoid receptor antagonists come in. And I'm going to talk about non-steroidal MRAs, not just finerenone, because there are other additional non-steroidal MRAs that are soon to be evaluated in clinical trials. But of course, the ones that are available, the one that is available to us in clinical practice is finerenone. And the data for the use of finerenone in people with diabetic kidney disease comes from the Fidelity population, the pooled Fidelio and Figaro trials, which collectively recruited 13,000 patients with albuminuric type 2 diabetes and kidney disease. You can see here the spectrum of kidney disease risk that was enrolled. And in the pooled analysis of Fidelity, the investigators looked at a composite endpoint of doubling of serum creatinine, kidney failure, or death due to kidney failure, as well as a composite cardiovascular endpoint that included 4-point MACE and hospitalization for heart failure. And you can see here in the overall Fidelity population, a 23% risk reduction in kidney disease progression overall, and a moderate 14% risk reduction in cardiovascular events, predominantly driven by hospitalization for heart failure. Again, a really interesting pattern to observe, given with SGLT2 inhibitors, you can see a strong signal for heart failure, less of a signal for atherosclerotic events, and it might be the same with finerenone. Of course, finerenone is being tested in a broad program in heart failure now, and we're going to have data on the effects of finerenone in HFpEF, hopefully being presented in 2024, and a range of other heart failure trials starting also in the new year. And I should just also mention that there are other non-steroidal MRAs that are being evaluated, balsirenone in heart failure and CKD, and also osidurenone as well, potentially in heart failure and CKD. So a very interesting space. And of course, with the aldosterone synthase inhibitors that will soon be evaluated in large phase 3 clinical trials, therapies that are targeting the MR axis have become very attractive and new again. So a really interesting space in diabetic and non-diabetic kidney disease. But what happens when you, or what potentially could happen when you use these three therapies together? Now, because the Fidelity trials were conducted around the same time point that the SGLT2 inhibitor trials were conducted, there were a relatively small number of patients who are on SGLT2 inhibitors at baseline, about 5 to 7% overall. Here you can see the data for the effects of finerenone in Fidelity stratified by baseline SGLT2 inhibitor use for cardiovascular outcomes and kidney disease progression. And although the numbers are small, and that's reflected in the wider confidence intervals in people receiving an SGLT2 inhibitor at baseline, there is no evidence that the benefits are attenuated in people receiving an SGLT2 inhibitor, with no statistical evidence of interaction with these therapies, indicating that there are independent and additive effects of these two classes of medications. That's important, but what about some of the potential safety synergistic effects? Well, we know that finerenone increases the risk of hyperkalemia, like all therapies that target the mineralocorticoid receptor. And interestingly, when you look at the finerenone trials, this Fidelio, the diabetic kidney disease outcome trial, you can see that there is a clear association between SGLT2 inhibitor use and a lower risk of hyperkalemia. Indeed, there were no events of serious hyperkalemia greater than 6 in patients receiving an SGLT2 inhibitor in Fidelity. And this dovetails really nicely with some of the insights that we've been able to gain from the SGLT2 inhibitor trials. When you look at Credence and you look at the outcome of central lab measured serum potassium greater than or equal to 6 in Credence, you can see that canagliflozin reduced the risk of serious hyperkalemia by about 1/5 overall in a proteinuric diabetic kidney disease population. And then we extended that across a wider cardio-renal-metabolic spectrum in about 45,000 patients and people with high cardiovascular risk or with kidney disease. And here, this is, again, a harmonized endpoint, reanalyzed across all of the trials, central lab-defined serum potassium greater than or equal to 6. You can see a moderate reduction in serious hyperkalemia, which begs the question, or raises the question, could using SGLT2 inhibitors enable better use of MRAs? And that's exactly the point that's exactly what you see in heart failure trials. And remember, in heart failure with reduced ejection fraction, in those SGLT2 inhibitor trials, about 3/4 of people are on an MRA. So that provides a really interesting opportunity to evaluate that question. These are data from EMPEROR-Reduce that showed here a reduction in risk of MRA discontinuation in heart failure with SGLT2. So building on this story that I mentioned earlier with enabling persistent RAS blockade, enabling persistent use of MRAs by reducing the risk of hyperkalemia. And some of you will have also seen this data from Hiddo Heerspink and the European investigators, a small trial, but a really elegant study that demonstrates that dapagliflozin, eplerenone, and their combination reduced albuminuria by more than either of them alone, and that adding dapagliflozin to eplerenone, a steroidal MRA, attenuates the increases in serum potassium. So we now have multiple lines of evidence from clinical studies that the use of combination therapy is not only beneficial from an efficacy point of view, but it might also enhance, or probably also enhances, safety and tolerability by reducing the risk of hyperkalemia. So we have these three therapies now that all interact with each other, producing independent and additive effects and potentially enabling better safety with their combined use. And I've given a version of this talk recently in 2023, and it's interesting how it has evolved. I had a question mark over GLP-1. I've had to remove that, and I'm going to show you why, as you will see in the following slides. With the GLP-1 receptor agonists, there has been a lot of fanfare about this class of agents. You will have seen it. The recent SELECT trial, which was a non-diabetic cardiovascular disease population, showed that semaglutide reduced cardiovascular events, reduced all-cause mortality in obese, non-diabetic patients with established cardiovascular disease. That was presented at AHA. Here are the data for diabetes and kidney disease outcomes. What you can see, this is up until 2021, that reductions in kidney disease progression are predominantly driven by reductions in albuminuria. And when you take out albuminuria, the effect was uncertain. ELIXIR was an acute coronary syndrome trial. If you exclude that, it becomes nominally significant. But at least from the data that we had available, there was the suggestion that there was a moderate effect on preventing kidney disease progression with GLP-1 receptor agonists in patients with type 2 diabetes. Of course, those trials were predominantly people with low kidney disease risk. How about when we look at the continuous outcome of annualized change in GFR, which gives us better power to detect treatment effects on clinical outcomes? These are data from SUSTAIN-6 and LEADER pooled by Armin Sharma and my colleague Vlado Perkovic. And you can see here semaglutide in blue, liraglutide in orange, and the annual difference in GFR slope, a taller difference, a taller column indicating a larger effect. You can see here that overall with semaglutide, there is an attenuation in the decline in kidney function, or a benefit on GFR slope. And that effect appeared to be larger in people with a GFR less than 60. So certainly promising evidence from an intermediate endpoint of GFR slope that these drugs reduce kidney disease progression. And of course, all of this was the background and rationale for the FLOW trial, which is the only dedicated kidney outcome trial of a GLP-1 receptor agonist, semaglutide. It enrolled about 3,500 people with type 2 diabetes and albuminuric kidney disease. Composite primary endpoint that was the same as what we used in the SGLT2 inhibitor consortium and in DAPA-CKD, 50% decline in GFR, kidney failure, death due to cardiovascular or kidney disease, with about 15% of people on an SGLT2 inhibitor at baseline. This trial is ongoing at the moment, but you might have seen that in October, the FLOW trial was stopped early by the Independent Data Monitoring Committee for Efficacy. And on the same day that Novo Nordisk released that press release that FLOW was being stopped early, DaVita in the US also released a press release in response to that press release after they lost several $1 billion in share price. Just an extraordinary series of events, how a trial press release can cause a dialysis company to then issue a press release. So this will be really interesting. We're expecting results in spring 2024, and very important data on preventing kidney failure with GLP-1 receptor agonists and semaglutide. We know that, so where do we stand now? We know that the complex pathophysiology that underpins the development and progression of kidney disease and type 2 diabetes calls for a multifaceted approach, but we haven't had the tools to be able to do that for a long time. But now we do. We've got RAS blockade and SGLT2 inhibitors that, amongst their other mechanisms, reduce intraglomerular pressure. We have finerenone, potentially other non-steroidal MRAs, which reduced inflammation and fibrosis. And of course, now we have the GLP-1 receptor agonists that address the underlying metabolic abnormalities, the pathognomonic of type 2 diabetes and kidney disease. And this kind of pillared approach, which we're focusing on today, is reminiscent of what the heart failure cardiologists do to tackle heart failure with reduced ejection fraction. And at least to me, it's very interesting that at least 3 of the 4 pillars are very similar to what is being used for heart failure with reduced ejection fraction. And potentially next year heart failure with preserved ejection fraction, which underscores, again, the close overlap and intersection between heart failure and kidney disease, particularly in people with diabetes. So the clinical trials that established these therapies all recruited people over and followed them for about a median of 2 to 3 years, actually close to 2 years in many cases. But we know that typically patients are treated for much longer time periods in routine practice. And understanding the lifetime benefits of using these medications in combination is useful not only for shared decision making between us and our patients, but potentially also payers who make decisions about access to therapies. And so what we did very recently was we did a cross-trial actuarial analysis where we looked at SGLT2 inhibitor trials. We actually used all 13, but focused on Canvas and Credence as the base population. All of the non-steroidal MRA data, all of the GLP-1 data, looked at all of the cardiovascular, kidney disease, and mortality endpoints. And we calculated what the theoretical combination treatment effects would be of using these therapies together, which was the multiplicative product of all of these, of the treatment effects in each of the derivative trials. And we applied these treatment effects to people with at least microalbuminuria who were receiving RAS blockade in Canvas and Credence. And we used these non-parametric Kaplan-Meier-based age methods where we used age as the time component. So entering the time zero as your age rather than the time from randomization. And the time of the event is your age at the event. Because we know that the benefits of treatment will depend on when patients start that treatment, any given treatment. And we use this method to calculate survival estimates for every age between 50 and 65, because that was the bulk of the population in Canvas and Credence. And what I'm going to show you here is the combination treatment effects of single, dual and triple combination therapies on top of RAS blockade. So compared to RAS blockade alone. You can see here for the primary outcome in this analysis of MI, stroke, or cardiovascular death, that there is a gradual and progressive increase in the relative treatment effect, such that combination therapy with all three agents, or 4 compared to 1, including RAS blockade, is associated with a 35% reduction in risk of MACE. I'm going to now show you that for hospitalization for heart failure. And you can see here very clear and substantial risk reduction with the addition of each successive therapy, and also that same pattern of effect observed for cardiovascular death. Now I'm going to show you that for kidney disease progression, doubling of serum creatinine, or kidney failure and all-cause mortality, and exactly the same pattern of effect here with very large relative risk reductions with combination therapy and a similar pattern of effect for all-cause mortality. So how do we put that in absolute terms? Well, if you take the average 50-year-old patient with about 0.5 gram of albuminuria in the pooled Canvas Credence population, and you treated them with RAS blockade and risk factor modification alone, their mean event-free survival in terms of MACE is about 18 years. With the addition of combination therapy, that's extended to about 21 years, meaning an additional 3 years of event-free survival, or survival-free from MACE. And you can see that the benefits are largest in absolute terms starting therapy earlier. What I'm going to show you now here is the same information, but for hospitalization for heart failure. You can see here overall more than 3 years, or about approximately 3 years of additional survival free from hospitalized heart failure with combination therapy compared to RAS blockade and risk factor modification alone. And this is the main difference. Of course, many patients will experience more event-free survival and some less. And of course, it's not surprising that then the differences in kidney disease-free survival are substantial, given this was a population enriched for people at high risk of kidney disease progression. 5.5 years of additional dialysis-free survival with combination therapy compared to RAS blockade alone with SGLT2, non-steroidal MRA, and GLP-1s. And again, a similar pattern of effect observed for overall mortality. And So this is really important and interesting, and I think for the highest risk patients, we'll be increasingly moving to using multiple tools to reduce their cardiorenal risk. How are we going to do that practically? And I just wanted to outline this is a bit of a vanguard slide that I put together very recently. How are we going to do that in practice? How are we going to use the 4 pillars? Well, the traditional approach, the fallback approach, what we all do is, you add an SGLT2 inhibitor, maximize the RAS blockade, reevaluate, regroup in about 3 to 6 months, consider this, consider that. Now, what are the drawbacks of that kind of approach? Well, firstly, it ignores the excess early cardiovascular risk, and I'm going to explain exactly what I mean by that. And additionally, what I think more importantly, or at least as importantly, is there is an extremely high risk of therapeutic inertia. I don't have slides to show you at the moment, but one of the reasons why polypills always win over traditional approaches for blood pressure control is not because they improve adherence, but they reduce the risk of therapeutic inertia and changes to therapeutic regimens. And I think that is a major risk with what I am going to call here the traditional approach to implementing the 4 pillars. What's the alternative approach? Well, the complete opposite is go hard, go fast, and go early. That is increasingly the paradigm which is being adopted in heart failure, based on the understanding that everyone with heart failure with reduced ejection fraction is at very high cardiovascular risk. Now, we may or may not be able to make that argument in kidney disease. And the other consideration to think about is the optimal sequence and timing for initiating these multiple therapies is as yet uncertain. And finally, I'm going to propose an alternative approach, which is in some ways a hybrid of the first two, which is identifying those patients at high risk of kidney disease and cardiovascular disease progression, and in those patients prioritizing accelerated implementation. And this is attractive, but there's a lot more work to be done. So what's the rationale for upfront combination, or why does the traditional approach, I think, fail patients? And I just did this last night, but I went back and had a look at the levels of albuminuria in credence, and here that's the panel on the left. These are patients who are treated with RAS blockade at baseline maximum tolerated. You can see that for a lot of patients, an SGLT2 inhibitor, you just know that it's not going to cut it in terms of reducing the albuminuria to a level that reduces their risk to a satisfactory level. And for those patients, adding multiple therapies fast is really going to increase the likelihood of reducing their overall risk in the long run. And that's important because of the data on the right. And I just truncated the credence follow-up to 12 months and had a look at how many events occurred in the first 365 days. You can see here that there are, over 4 times as many, almost 4 times as many hospitalizations for heart failure or cardiovascular death than there are kidney failure events in the first 365 days. So although we think of kidney disease, people with kidney disease as being quote unquote stable, what that does is it ignores the excess cardiovascular risk that is faced in people with diabetes and kidney disease, particularly proteinuria type 2 diabetes and kidney disease. So perhaps the strongest rationale for upfront combination therapy is actually not a kidney disease rationale. It's actually preventing patients from experiencing heart failure and cardiovascular death. When we talk about rapid sequence initiation of disease-modifying therapy, trials like Confidence are going to be really important. Confidence is recruiting about 800 patients with diabetic kidney disease, a credence-like population, if you will, and it's testing simultaneous initiation of empagliflozin and finerenone versus both of them alone. And so it is conceivable, and it's potentially achievable, that you could add in all 4 components of guideline-directed therapy for diabetic kidney disease within about 2 months, although that remains to be tested. The other approach, which I mentioned, is the hybrid approach. This is accelerated implementation based on baseline absolute risk, or risk-based approach. And what I'm proposing here is that we use validated risk scores like the KDIGO heat map or the KFRE or CLIN risk, which is a newer equation, to identify those at highest absolute risk. And in those patients, prioritizing accelerated uptake. And these are a little bit older now. This is data from Canvas, but what I did was categorize everyone according to their overall KDIGO risk. Green, orange, red, and dark red, and for low, moderate, high, and very high risk, and looked at the absolute benefits of treatment. How many events were prevented per 1,000 patients treated over 5 years? And what you can see, there's a clear pattern for all of the outcomes, is that the absolute benefits of treatment are largest in people with high KDIGO risk, supporting the idea that we can use validated risk scores to identify those who benefit from treatment the most in absolute terms. So perhaps this is a hybrid approach that combines the first two approaches, and that needs to be evaluated in future trials. Finally, I just wanted to make a note about implementation more generally. Cost is a major issue. There's no question about that with some of these newer therapies, but we have for now many years RAS blockade data that shows that this class of medication is underused in people with kidney disease, and it's not related to cost. And I think part of the problem is that our current paradigm is that we think that we go to Ottawa Grand Rounds or ASN Kidney Week and we understand the data and we then can apply it to our patients. But the reality for the uptake of all of these proven therapies is probably much more complex. At every stage in the interaction between our patients and the healthcare system and us, there are opportunities for people to fall through the cracks. There are systems, providers, and patient barriers to uptake of these disease-modifying therapies. And I think for us in nephrology, the time, if we don't do it now, we're going to be caught behind in about 5 years' time. We need implementation research that understands and addresses these barriers for uptake of therapies and designs strategies tested in randomized settings to improve the uptake of proven therapies in people who need them most. So in summary, our recent trials have established 4 pillars of therapy for diabetic kidney disease. The evolving standard of care in 2024 is now combination cardio-metabolic therapy with RAS blockade, SGLT2 inhibitors, non-steroidal MRA, and GLP-1 receptor agonists. And I think the most reasonable thing from a clinical perspective is we need to match the intensity of treatment to patients' cardiorenal risk. The next generation of trials that we're going to be seeing in this field is going to evaluate different combinations of therapy for different patients, as well as implementation strategies to improve their uptake, as I've mentioned. And of course, ensuring equitable access and optimizing implementation will be critical to realizing the population benefits of these new pharmacotherapies. And so with that, I'll conclude and very happy to take questions and looking forward to the discussion. Thanks very much for your attention.
Thanks, Brendon. That was a beautiful overview of the topic, and thanks for sharing some of the new research you have done. So if people have questions, please raise your hand and ask them, but I can start the ball rolling. You mentioned that GLP-1, Flozins, non-steroidal MRAs can be independent. What about RAS inhibition? Do you want to address the fact that some patients may not be tolerating either ACE or ARB? And is it okay to still, because all the trials had background RAS inhibition, is it still okay to use any of these drugs?
Yes. Now, I'm glad you asked that. Can I show you something? Hopefully I've got it somewhere here. This was accepted by the New England Journal, but they took it out because I was a bit upset at the editorial for the Kidney paper. So we've got data now that you're absolutely right, Swapnil, that some people, for whatever reason, hyperkalemia, fluctuating kidney function, other intolerance, they can't tolerate RAS blockade. And there are many patients, there are patients like that. In the SGLT2 inhibitor trials, there are also patients, a small proportion, who were not on RAS blockade at baseline. In EMPA-Kidney, they enrolled non-proteinuric, non-diabetic patients. There's not a strong indication to use RAS blockade in those patients. What are the effects of SGLT2 inhibition in people with and without RAS blockade? You can see here that even in people without RAS blockade, there is a reduction in risk of kidney disease progression in that population with no evidence of interaction across statistical interaction across those two subgroups. But importantly, there looks like there's a real treatment effect in the non-RAS blockade population. And I think, I haven't seen the data yet, but George Bakris, I saw him a week or two ago. I think there's something coming out in JASN soon. I don't know if anyone's seen it, looking at SGLT2 without RAS blockade. So I can't, and I think we haven't even touched this conversation yet about sequencing and timing. And I think there is a potential rationale, or there is an argument that SGLT2 upfront is not a bad way to go, because there's no dose titration in the treatment naive patient. There's no dose titration. There's no hyperkalemia risk. And then perhaps, then you can add on other things like the RAS blockade and titrated. So if you look at the experience from heart failure, the traditional approach is always follow history. You just follow that, you add on what comes next historically, but that paradigm is being challenged, and we haven't yet even had that conversation in nephrology, but I anticipate that we're going to have it soon.
Fantastic. Dr.